Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Hey, welcome back to the Equine Vet Connect podcast. I'm Dan Carter. We're here at Countryside Equine Hospital. Got Dr. Zoe Latimer with me today. She's one of our other vets that does quite a bit of sports medicine. Really cool topic today. I'm a little bit of a nerd on this. We're going to be talking about regenerative therapies and joints, basically the use of biologics, and a lot of really cool stuff in this field. This is it's kind of amazing. Zoe, you basically grown up in the vet world where biologics have been around, right?
Yeah, seems like it. Well, it was like not super common. I feel like you had to be like one of the rich kids to have IRAP done on your horse.
Oh, good old IRAP. Yeah, I remember when IRAP actually
cool.
first
cool
came
kid.
out, and they were talking about this really cool thing called IRAP.
Mm-hmm. That was big stuff.
Yeah, it was big. It was huge, right? It was like,
Yeah.
It was like, oh, I can send a text message on my phone by pushing a bunch of numbers, right?
Yeah.
Like it was kind of it was like the precursor to what we're going to talk about today.
Mm-hmm.
It was kind of a really cool thing some nerds figured out, and
I remember in high school, my horse got a tendon tear, and they're talking about putting PRP in the tear.
that's big
And
stuff.
that was like.
Like cutting edge.
Yeah.
All right, cutting edge. So
I feel like 20 years ago, that was not a thing.
20 years ago, it wasn't.
Right.
You know, when I was in vet school, I'm going to show my age over here, graduated 15 years ago. In class, we talked about there's this stuff called PRP, or platelet-rich plasma. And there's this stuff called IRAP. We're going to touch on it briefly because we don't know much about it, but it seems to be working. And this is like cutting-edge stuff, right? This is like we're just starting to dabble in this crazy world of stem cells, and then this crazy world of these biologics. And I remember I had one of the first machines in Georgia to process IRAP because it was that new, and being a nerd, I was like, I gotta have this.
What a time to be alive.
Yes. I mean, it was big stuff. So
Yeah.
now it's a lot more mainstream. And
But what's the big deal, Dan? What's all the rave about? Why do people care so much about biologics? Because the traditional joint injection is a good old steroid.
good old steroid. Well, like everything, we eventually learned that there's better ways of doing things. Maybe pregnant women shouldn't smoke Pall Mall cigarettes.
Yeah. Okay. Yeah.
We learned. Okay. Mm-hmm. And that's one of the things I tell people is with the introduction of biologics, we've really had to change how we think when we use. And that's a little bit what we want to talk about today is.
But biologics is the umbrella term for stuff we harvest from the body.
Correct.
That we then inject into the horse.
Right. So biologically created substances that we can then use to help treat the horse. Yeah. And if you really want to think about it, we're basically hijacking the body's own mechanism of healing and sort of just ramping that up a little bit.
We're making the immune system work for us.
Work for us.
Yeah.
Which, if you've ever been around horses, most of the time the immune system is not helping us.
They're so pro-inflammatory. It's not even funny.
So, if you've been listening to the podcast, it was a few weeks ago. We actually did a talk on joint health. We touched we did kind of a deep dive.
A couple months ago now.
Could have been. We've been doing this for a while, haven't we?
Was it the second episode? I don't remember now.
Yeah, maybe second, third. Flip back through, you'll find it. So we do a deep dive, and if you haven't listened to that episode, if you want to help yourself out, push the stop button now, go back to that episode, listen to it, and then dive in here. We're going to touch briefly on joint anatomy, physiology, what's going on inside this joint.
Right.
But then we're going to
We're not going to
dive
spend too
right
much
off.
time doing that because
Right.
this is kind of episode 2 of joints.
Yes.
Yeah. So episode 1, we do a little bit. We'll do a brief overview.
So when we get into a joint, we got to go back to what a joint's composed of. You've got a joint's basically where 2 bones meet. Where those 2 bones meet, we have articular cartilage. That whole joint's encased in a joint capsule. That joint capsule's got some thickenings in it called collateral ligaments. Then and then the lining of that joint capsule is called the synovium. Synovium is where we produce joint fluid. All right. If you go back to that episode, you remember we saved the cheerleaders, we saved the world, we saved the synovium, we saved the joint. So the better.
I forgot about that analogy.
Yes. It's very important. Like, so the synovium is what produces the joint fluid.
Yeah.
The joint fluid is what maintains the health of the joint. Correct. The joint fluid nourishes the articular cartilage. Articular cartilage doesn't have a blood supply. It relies on the health of that joint fluid so that it can stay healthy.
Why do we need articular cartilage, Dan?
I mean, that is the gliding surface of the joint.
Why do we need to glide?
Because that keeps us from limping.
Yeah.
In a real simple term, the better the articular cartilage, the better the joint. The healthier the joint capsule, the healthier the joint.
It's true.
The healthier the joint fluid, the healthier everything is in there. So really, if you boil this down and you really get it simple, the healthier the joint fluid or the synovial fluid, they're synonymous, the healthier the joint.
Yeah.
And the healthier our synovium is, the better joint fluid or better synovial fluid we make. And so really when you think about it, we're really just trying to make better joint fluid.
Yep.
So, anytime you have an inflammatory event in a joint, you're going to produce some things, right?
Yep.
You're going to produce old interleukin-1, some TNF-alpha. Those are big ones, right? When those things get produced, let's draw a picture. We need pictures. If you're not watching this on YouTube, you're going to miss out.
Picture on my other sheet. It's in the other room.
They're going to miss out. If they're not watching this on YouTube, they're going to miss our drawings. Let's do some drawings here, Zoe.
Okay.
So, what I think about is beautiful.
We're doing a joint, right?
Yeah, let's draw this little joint here.
Wow.
And our biggest thing is what happens when this joint becomes inflamed, because we're going to get a release of a lot of several different things. One of them is prostaglandin. If you've ever had heat redness or swelling, you know what prostaglandin is. So if you were to get a bruise and it hurts, the product that's making that happen is prostaglandin. That's beautiful. So when we let me borrow this.
Yeah.
All right. So.
Don't mess up my drawing.
I know. So my favorite drawing in the world is you produce this stuff, interleukin-1, okay? Interleukin-1 comes down, and it's like it binds in here, right? So we're going to call that a receptor. All right, it's actually going to bind into this receptor.
IL-1 is an inflammatory cytokine.
It's really bad stuff. So when it binds this receptor, bam, 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 we're going to produce 3 things. We're going to produce some prostaglandin. We're going to produce MMP, matrix metalloproteinase, and some collagenase. Okay.
All bad things.
All right.
For the joint.
Yeah, these degrade the joint. They're bad.
They make your joint fluid watery.
Yep.
Gross.
A non-Newtonian fluid. So when this happens, these are breaking down the joint. So earlier when we talked about steroids, we can block this whole thing, right? Because we actually block the production of interleukin-1 with a steroid. A lot of what we're going to talk about today is blocking the downstream effects of IL-1. And if we go back and remember, when these things are created, they actually go back to the joint, target the joint capsule, and then they also target the articular cartilage, and they cause breakdown of that articular cartilage. And then those actions actually feed back up and make more interleukin-1. So it's a really terrible cycle when you think about it.
Yeah.
So, again, inflammation begets more inflammation.
So when we go in and inject joints, aka the OG, we inject them with steroids.
Mm-hmm.
The whole reason we do that is to go in and try to break this cycle.
Right.
So the IL-1 that produces the prostaglandins, the MMPs, the collagenase, which then acts within the joint to then produce more IL-1, so this negative cycle. The reason why we inject joints is to go in and try to break this cycle to stop the production of the IL-1.
That's it.
But then enters biologics as well, which offers a alternative to said steroid injections. So,
Correct. And there's a lot of other benefits that we're going to talk about with biologics beyond just decreasing this inflammatory response. All right, there's some good things in there too. So IL-1, that we call it a cytokine. If you're under 40, a cytokine's a text message. Okay, you'll understand it's like a little text message. I guess it could even be like a Snapchat for your generation. Maybe my generation, it is a text message. Your generation, it's a Snapchat, right? It's a signal, right? It's a nonverbal signal that goes out that tells people what to do, right? Mm-hmm. Okay. So we got to stop that. The other thing that these biologics work on is they do have good growth factors in there. So we have good and bad growth factors, just like you can have good and bad text messages, right? Mm-hmm. So you've got good growth factors that actually help to rebuild the joint. Like we call them we call them anabolic growth factors, or growth factors that actually promote healing. Mm-hmm. So IL-1's breaking down the joint. The body also produces other growth factors that help to build the joint back. Mm-hmm. And you're in a constant battle with these. And so if you think about it, we want to get rid of the bad and increase the good. And that's
always the goal.
Yeah, that's where biologics come in, because like you're talking the OG steroid, we decrease the bad, but we're not putting any good back in.
Yeah, which, I mean, it's a good place to start.
Absolutely.
Decreasing the bad is always a good place to start. But once we know better, we do better, right?
100%.
So if we have an opportunity to not only decrease the bad, but also then increase the good, wouldn't we want to do that?
That is definitely, that's why biologics are gaining in popularity.
Yeah.
Now, there are certain times where you may not want to reach for biologic. I always say, like, if you got a forest fire, you need to go grab your steroid. Like, you need a steroid, because a biologic's great, but it's not as powerful as a steroid.
Steroids are basically the most powerful anti-inflammatory that we have.
Absolutely.
And what he's talking about a forest fire is if you are sitting there faced with a joint that is out of control, inflamed, sometimes you just need to get in there with a steroid and just make everything calm down first.
Yeah, and there's a lot of times where I'll use a steroid as, I think about like a fullback in football. It's my lead blocker, right? Like, put the forest fire out. And then we're going to come in that 35, 45 days later, and we're going to start introducing a biologic. Or maybe be later, like, hey, we're going to hit this today, but before we get to this situation again, we got to get a biologic in this joint.
Yeah.
So
we want some of that good stuff in the joint,
right.
too.
And so we're going to get into that when we really start talking about when we reach for a biologic. Mm-hmm. So
yeah.
And I think that kind of leads us to knowing what's going on in the joint. I think forever we throw out this term arthritis or osteoarthritis. We just throw it out there like, oh, he's arthritic. Mm-hmm. Well, arthritis just means inflammation of the joint.
Arthritis is a huge umbrella term, number one, and there's a huge gray scale. Arthritis can be very mild to very severe to cause of death. I mean, because a horse can be so crippled from arthritis that they don't want to get up anymore. Therefore,
end stage.
Yeah. So, and very, very mild can look like, oh, we just have, just a little bit of inflammation within the joint.
We're just not performing as well as we used to.
Right. A little bit of synovitis. That's the beginning. That's how it starts.
Well, and that's a good point you bring up. You said the word synovitis. It's like you got this catch-all term for arthritis, but again, arthritis is just a big blanket term that says the joint's inflamed. But the real question is, why is the joint inflamed? Mm-hmm. Is it just I shouldn't say just, but it could be a synovitis. So the joint capsule itself, the synovium, is actually inflamed. Mm-hmm. We could dig deeper and have issues with articular cartilage. We may have an issue with the bone plate underneath the cartilage. So we call the subchondral bone plate, and it sits underneath that joint cartilage, we could actually have an issue there. Oh yeah, it would sit. Forgot our artist Zoe drew this. So if here's our cartilage, the area of bone right underneath of our cartilage, right in this area, that is your subchondral bone plate. And you can actually get fissure fractures in that bone plate, which then can lead to arthritis in itself.
Right. Also, when you get like cartilage that starts, if you were in there with a camera inside the joint and looking, you can get cartilage that looks kind of like an eggshell where it's got all these little divots in it.
Right.
That's like sick cartilage. That's when like those gels, like Arthromed goes in and just lays in all that. That's nice.
Yeah, there's a lot of time.
Ultrex just goes in.
Yeah, beautiful.
Yeah.
We're going to talk about that. We're going to get into a whole episode on polyacrylamides, and I'm pretty excited about that.
We'll get there.
The other thing, and we get quite a few cases of this, is the joint's inflamed, and you can actually, so on the side of this joint, you've got a collateral ligament. If you've ever heard about people tearing their MCL in their knee, that's the medial collateral ligament. So you've got one on each side of the joint. The medial just means the inside, and the lateral is the outside. But you can actually get MCL tears in these joints. Fetlocks is actually quite common to have an MCL injury in that fetlock. That leads to instability in the joint and then leads to arthritis.
Right. Basically, you twist your ankle, you get swelling in the joint, which then sets up an inflammatory environment. There you go. There you have your cascade.
That's a really good point. Most people have experienced a sprained ankle at some point in time.
Yep.
You've experienced a mild injury to one of your collateral ligaments. The swelling that you see in that joint is a result of instability that resulted in synovitis, capsulitis, and then we blanket the whole term as arthritis.
Right. Arthritis is right. Correct. Yeah.
So I think when we talk about this, again, it goes back to a lot of the things we talk about on this podcast is knowing what you're dealing with, having that understanding of not just, oh, it's sick. Well, why is it sick? And that's no different here. It's like, well, the joint's inflamed, but why is the joint inflamed? And having that understanding of why the joint's inflamed, I think, is really, really important.
Right. And getting to why the joint is inflamed, a little bit of a diagnostic process, but,
Worth it.
absolutely worth it.
Some things we may do is joint blocks. I love a joint block.
So do I.
Yes.
I love it.
And we got some generalized rules, some time and how long. And so for those of you who wonder, a joint block is where we actually take carbocaine, which is similar to a lidocaine, and we inject it straight into a joint. And we actually numb that joint. It's a temporary analgesia of that joint.
Yep, we go in sterilely as if we were going to be doing treatments on the joint, like a steroid treatment on the joint. We go in very clean with that clean bottle of carbocaine and numb the joint essentially, and trot them out, see what happens.
And it's kind of cool because we got some rough rules. If they block right away, it gives us some idea where we're looking.
Yep.
Yeah, I'll go out to
because we put
my
the
limit's like 15
carbocaine
minutes.
directly into this pocket.
Yes.
So if they block within like 5 minutes, you pretty well know your pain is. I guess it's like a general rule of thumb. It's like if the sooner they block, it's like it's pretty well like within the joint, and then the longer you have to wait for them to block out. People say like in general, like if they don't block out for like 15 minutes, it's because it took that long for the carbocaine to diffuse out, and you probably have some deeper structures that are involved in the process, like the deeper like subchondral bone or maybe the capsule. It just took that long or maybe a collateral ligament or something. So
Yeah, I like how you put that guidelines. I remember I used to think they were like rules, right?
No,
they're suggestions.
And horses are always like, yeah, whatever.
Yeah, they'll make it up.
I just say in general.
Yes.
The sooner it blocks out, you're like, yeah, okay, this is definitely the joint.
I love when blocks in 5 minutes because it's like I am probably dealing with a straightforward synovitis in this joint, and I'd rather start with a synovitis. It's that one that gets to 15 minutes. I'm like, do we have collateral ligament involvement? Is our subchondral bone plate not happy?
Yeah.
And then that's going to lead us into, imaging. And oftentimes, like I think this is one of my things is, you'll take an X-ray, you'll see a bone spur. And a bone spur can be either an osteophyte or an enthesiophyte. Just an osteophyte, and really, I'll be honest, I think most of them are enthusiafites, so splitting
I
hairs
agree.
here.
They're right where, most of the time, right where ligaments either begin or end, so.
So, and I think so what is an enthusiaphyte? An enthusiaphyte is a bone growth where soft tissue attaches. So whether that be the joint capsule that's attached there or a collateral ligament that's attached there, if you have a bony growth, then that's an enthusiaphyte. And a lot of people want to call those osteophytes, and that's
Which to me further signifies, kind of like how we discussed that a little bit, how you told me one time, maybe a couple of years ago, that like when you see side bone, it's an indication of an instability in the joint. When I see a bunch of enthusiaphytes, to me it signifies instability in that joint.
100%.
Like chronic instability
Yes.
of that joint.
100%. That
Because
tells
it's like
me
your seatbelts are just like holding on for dear life.
That's it.
All the time.
Yes. and that's
You
an
have a bad
indication.
driver.
You got a lot of those, like you said, like, okay, yeah, we got a problem here. What is our real problem?
Yeah.
And we need to go look a little bit deeper.
Yeah.
I'm an ultrasound guy. I love an ultrasound. I'm probably going to clip that joint. I'm going to look at those collateral ligaments on ultrasound.
Yeah.
An MRI will always be like the end all be all. But, I think we often forget, like, if you're skilled with that ultrasound, you can get a lot of information from the ultrasound, right? You can see that joint capsule. You can see those collateral ligaments. I really love an ultrasound. So,
Although I never will get over, there have been like just some very impressive x-rays I've taken, and I'll never get over the clients, just when the clients can see it and they go, oh, I love that. This is one of my favorite things, because like clients can read x-rays pretty well. Ultrasound is a little harder. I feel like most people don't really know. I think ultrasound's just harder, I think.
Yeah.
But an x-ray, most people can look at an x-ray pretty well. And so when they can see on the x-ray, and they're pretty impressed by it, I just get a kick out of it. I think it's fun.
Well, I think
it's fun when the clients get involved. So.
Well, and I think that leads to, like, you talk about that x-ray, it's like, oh!
Yeah, when they go, oh, what is that? I'm like, exactly. That's what we're here for, right there.
I think that's one of the cool things about the biologics is we look at these joints that you would see and they'd have that reaction, and you're like, ugh, what are we going to do? Well, now with these biologics, there's so much more we can do.
Yeah.
You see some of those joints, like we were done. And I think, that's the other big thing that, I heard a man, he was talking about regenerative agriculture, and he said, you don't have to change how you think, you got to change how you see. And I think with biologics, that's what we're having to do, because initially these biologics were, all right, nothing else is working, everything's failed, let's go grab the biologic. And at least that's what it was when I started practicing. And we had to start looking and say, wait a minute, if that's our last ditch effort, is to go grab a biologic.
If you're using it
Why are we
when
not?
nothing else is working.
And it's working, why aren't we using it sooner? And I think that's where we've had to change how we see things, and we had to change how we look. So let's dive into some biologics. Like
Let's get there.
Let's get there.
20 minutes in, we'll finally start talking about some biologics.
This subject's near and dear to my heart. I could probably nerd for hours on this.
I think we talked about we'll probably end up having approximately 4 or 5 joint episodes. So this is episode 2.
Episode 2.
So y'all strap in. We're going to get into biologics. So let's brief overview. There's multiple biologics. We'll just kind of name them. So biologics are products that we are harvesting from the horse's body to then use in the horse. So they include IRAP, PRP, ProStride, Renovo.
Alpha-2 macroglobulins. I don't know why that was so tough
Blah,
to
blah,
say.
blah, blah,
Yeah, alpha-2 macroglobulins.
Yeah. I feel like I'm missing one.
That's your main ones.
Okay, yeah.
And the thing, I guess let's start from here. If we go back to what we were talking about with physiology of the joint, if we control interleukin-1, we can control the degradatory enzymes that it produces, and we can control the joint.
Oh, stem cells.
Stem cells.
That's what I knew I was missing.
Stem
one.
cells.
I was like, what? Yes,
Yeah.
okay, stem cells.
I sometimes
I'm sorry.
forget about those on joint. maintenance. We don't use them near as much as we used to.
Well, because they kind of cross over into injuries as well.
They really do.
But yeah, I feel like people use stem cells more in injuries than they do in joints. It's a little bit.
Yeah, on the side, I mean, that's one of the things I'll use if I got like a meniscal tear in a stifle. I'm reaching over and grabbing a stem cell quickly.
Yeah, that's a really good point. But also, again, more like an injury.
Yeah, collateral ligament injuries respond really well. So, the whole name of this game is we got to control interleukin-1. And I'm going to boil down regenerative medicine, and it really, you hear all this talk about regenerative medicine, which biologics fall into that category of regenerative medicine, and we talk about all these things involving regenerative medicine. But regenerative medicine sounds really complicated, but it's actually very simple. The body has its own mechanisms to deal with these situations. All we're doing is harvesting the body's own mechanisms for healing and sort of concentrating them, ramping them up, just sort of supercharging them a little bit and putting them back in.
Yep.
It's not complicated. We're just hijacking what the body automatically does and just sort of ramping it up a little bit.
Concentrating it way down to about 2 mils.
Yes.
And then injecting it
Yes.
where we want it.
So, if that joint, the joint may get a little bit when it's inflamed, and we do regenerative medicine, we give it a lot.
Yeah.
And that's really the magic behind what we're doing.
Yeah.
So, one of the products you mentioned, IRAP.
Mm-hmm.
All right, IRAPs.
Oh, actually, really important while we're talking about that. Because you're like, we're hijacking the body's own immune system and concentrating it down and injecting where we want, because there's no bleeding, there's no blood inside of a joint.
Right.
So it's important to note all these wonderful growth factors that we're concentrating down.
Mm-hmm.
They don't normally just float around in the joint.
They don't.
We have to put them there.
Yes.
So because the normal healthy joint fluid does not have any blood in it.
No, it all comes
So
from
it's not going to
synovium.
get these growth factors unless we put them there. So,
Again, save the synovium.
Yeah.
Save the world.
Yes.
So.
That's why joint fluid is always like nice, pretty, yellowy.
Should be.
It's not red like blood, so we had to put it there.
Yeah, occasionally it is red like blood, and that's a bad. That's what we call cirrus
Yeah.
sanguinis, and things are headed south.
That's when it's a little awkward. You're like, ooh,
Yeah.
ouch. Yeah, this horse has been hurting a lot more than he's been
Angry.
letting on. This horse is
Yes.
tougher than you think he is. Yes.
So we talk about IRAP, and then IRAP.
We'll start with the OG. I feel like
Yes.
IRAP was like first on the scene.
It was.
That's the first one I remember. It's like a horse with a giant blown up knee at my barn when I was like in middle school maybe, and they were coming every other week to inject that horse's knee with IRAP, and I was just like watching them, and I was like, because I want to be a horse vet one day, right? So I'm like little barn rat, just all up in there, like, what you doing? So, I feel like that was like an OG, or at least that's what I felt like.
It was the first biologic joint treatment out there.
Yeah.
It was the first.
So what does IRAP stand for? Excuse me, I've been a little sick.
It stands for interleukin receptor antagonist protein. So to boil that down, let's go back to our beautiful drawing here. Again, if you're not on YouTube, you should switch over. If you look, this little triangle is interleukin. It has to bind into that receptor in order for the bad things to happen. Basically, what IRAP does is it gets to this receptor first.
It says no.
And it like builds a wall. Bam.
It says you may not pass.
Yeah. So interleukin's floating around in this joint, but it's got no place to bind. If interleukin can't bind with that receptor, it can't do anything.
Yep.
It's like if you were trying to break into somebody's house, but you can't get through the door. If you can't get through the door, you can't steal anything from them.
Right.
You can't cause any problems.
Right.
So IRAP basically protects the door and just doesn't let that protein bind.
Yep.
And if interleukin can't bind, it can't have the release of all these other bad things, these bad enzymes in the joint.
And
So
IRAP. So IRAP we harvest from the horse's blood, and it's yellow. So and it's if you guys are familiar, if you've ever seen it done, it's multiple different treatments of syringes of just yellow fluid that we're injecting in the joint. And so what's the yellow fluid?
So basically what we used to do when we were making IRAP is we'd pull 60 mils of blood and we'd put it in this kit, and some nerd figured out that if you mix blood with chromium beads, we'd have to then put it in the incubator, cook it overnight, and it would actually, the IRAP protein's produced by white blood cells. So cooking it with these chromium beads and incubating it for 16 to 24 hours would cause the white blood cells to start to release all their IRAP. So all the IRAP's trapped inside these white cells. We cook it with chromium, and then all the IRAP is released into the liquid portion of blood. We would then take that out of the incubator, we'd spin it down, and we'd harvest the liquid portion of blood or the serum off of it, and then that would be high in the IRAP protein.
So basically, IRAP is just not letting the bad stuff bind.
Correct.
It's pretty rudimentary, all in all, but it's like, this is like brand new science.
15, 20 years ago, brand new science.
Yeah.
And it really led the way to where we're at today.
So then IRAP kind of paved the way to which then opened the door for PRP to come on the scene.
So when PRP stands for platelet-rich plasma. And what that is there's no incubation with it. So big difference is here. Serum, we let the blood clot and then harvest the liquid portion. Those growth factors get used up in the clotting cascade. So as the blood clots, we're going to use these growth factors up that are inside platelets. With PRP, we do not let the blood clot. Therefore, all these platelets are still around.
We want them.
We spin that blood down and we harvest the liquid portion, which is plasma, off of that. Inside that plasma,
which we now keep for other things.
Yes, platelet poor.
Yeah.
We'd harvest this, so we would take this platelet rich, we'd gather it, this plasma that has a ton of platelets in it. Most people have heard of platelets, like if you get a cut, platelets would show up and help you clot.
Yep.
The other part of a platelet is inside that platelet, it's got a cool thing called an alpha granule. And inside this alpha granule are tons of these good cytokines. They're growth factors that actually help the body heal. Insulin-like growth factor, tissue growth factor alpha and beta. These are like good ones. And so if you go back, like if you were to clot, something's got to drive your skin to heal, right? So not only does the platelet clot, but it releases these alpha granules. Those alpha granules dump all these good cytokines that recruit cells in to help you heal. And so all platelet-rich plasma is we harvest the plasma off of this. It's got a ton of these platelets in it, got a ton of alpha granules. We then inject that into the joint, and we get all these great growth factors inside the joint. And they actually help the body to heal. So we're not just stopping inflammation, we're actually
Putting some good stuff in.
Yeah, putting stuff in to help the joint heal. So if you do have some softening of that articular cartilage, we can promote that to heal. If you do have a collateral ligament injury, we can promote that to heal.
This was really a turning point.
It was.
Yeah.
It was.
Because before we were just kind of trying to stop bad things, and then PRP was kind of a turning point to then we're putting good things in.
So we're not just blocking the bad.
Yep.
We're actually putting in some good.
Yep.
The downside to PRP, it's very low in white cells. So we don't get the IRAP protein.
Yeah.
It's
comparatively now is pretty
correct.
Low. Yeah.
And that was always the big discussion, which we'll get into later, about high white cell, low white cell, which one's better. We'll talk about it on tendons, but in general, PRP has always been low in white cells. We don't have this expression or we don't have this release of the IRAP protein. So we get very little anti-inflammatory out of it. We get some great things to help it heal, but we're not doing anything with the bad. And if you don't stop the bad, you can't do any good.
Yeah.
Does that make sense? I hope that makes sense.
Well, because if you don't stop the bad, the bad uses up all of the good.
Right.
So bad, like when we say bad and like inflammatory cytokines will very quickly deplete all of your good anti-inflammatory cytokines.
So we got PRP, we've got IRAP. A new guy that's come on the scene. He's actually been around for a while. We were actually using this without realizing we were using it. Was the alpha-2 macroglobulins, and these are really cool proteins, right? Because they actually eat interleukin-1. I think about like Pac-Man, right? And it's actually got a protein structure inside this
Pac-Man
molecule
in the joint.
that like attracts interleukin-1 to it. Or not interleukin-1, but it attracts these enzymes like MMPs and collagenases. It actually attracts them, so it's like a moth to a flame. Like, it sees this little thing, and this enzyme's like, oh, I like you, and it goes over, and when the enzyme hits, it's like Pac-Man, like, don't, caught you. And it takes this enzyme out of play. So I've got this matrix metalloproteinase floating around in my joint. It's in there, like, tearing up my joint. But I've got this alpha-2 microglobulin that's in there, and he's like, hey, MMP, come over here, let's be friends, and then it eats it. It's like a Venus flytrap, and it eats this enzyme. Takes it out of play, it can't do any bad. And so that's your alpha-2 microglobulins, right? Mm-hmm. And we didn't realize, like, when we were doing, I really think when we were doing platelet-rich plasma in joints, the PRP in joints, we were getting some anti-inflammatory. Mm-hmm. And we now know that anti-inflammatory was coming from this alpha-2 microglobulin.
Yeah.
So we didn't realize we were getting some anti-inflammatory.
Right.
And it's not as concentrated because the alpha-2 microglobulins, they're more in your platelet poor plasma.
Yeah.
So if you spin blood down, right, you got your cells on the bottom, and then you got your platelet rich, and then on top of that, it's your platelet poor. Mm-hmm. And so it's actually striate. And Casey, maybe you can throw up an image of one of those tubes that's labeled with where everything's at when we centrifuge it down, the platelet poor, the platelet rich, and then the cellular fraction. Yep. For those of you who don't know, Casey is our person that helps us edit this podcast. So big thank you to Casey for figuring out how to do all this stuff. So
yeah, it settles out because there's different weights of all the molecules. Mm-hmm. So all the heavy stuff goes to the bottom, obviously, and the lighter stuff goes to the top. But you get a pretty cool distinction there.
And one of the next episodes we're going to kind of talk about, and we can touch on, well, I tell you, let's just go ahead and touch on ProStride.
I was going to say, like, we're going to do an entire episode on ProStride, so we're not going to get into the weeds. But if you marry IRAP and PRP together, you get ProStride, which now is pretty much made PRP and IRAP pretty obsolete. Yep. However, PRP still is used pretty commonly in, I feel like a lot of vets will use PRP specifically into like injuries, like soft tissue injuries, which they'll ProStride soft tissue injuries too now. But yeah. I feel like poor little IRAP barely gets used ever.
I think I still have an IRAP kit on my truck.
Really?
And I think it's because I haven't brought myself to taking it off the truck.
Oh. But is it expired? I feel like
long time
I was expired. Like, I feel like the sterility expires at some point.
Well, I think the only reason it's still on my truck, it's like IRAP,
it's like symbolic.
You were with me for so long. I can't bring myself to take you off the truck. It's like, it's like that old friend,
Since the birth of ProStride.
Yes.
Poor little IRAP just it's been in the back of the closet.
It has. It sort of became obsolete. But again, that's the cool thing about this field is...
I have to say, I have not IRAP'd anything in 4 years.
Have you ever done IRAP?
One time.
A
knee. One time during my first year as a veterinarian. But it's because we didn't have a ProStride machine. Back before I worked here at Countryside.
I think...
All we had was we had the ability to do IRAP and PRP, but we did not have a ProStride machine.
Actually, because this horse came in the other day, the last IRAP I did was 2017. All right, because that's what we had.
So this would have been 2020. So I've done one more recently than you have.
You have. So that kit's been on my truck for. But again, like,
that was 7 years, almost 8 years.
Am I going to pull it out and use it? No. It just kind of rides around on there, I guess, to...
Raleigh, take it off his truck.
I think it's just to remind me of the old days.
Yeah.
I'm never going to touch it, but I open it up, and it kind of reminds me of, like, hey, this is where we started.
Yeah. Kind of like when you carry your tube around.
Yeah. I used to tube horses.
Yeah.
I don't really do that anymore.
Yeah.
But I still have one. I have a pump.
It's just there for...
Actually, I did a colic the other night. I did a colic. I worked up a colic, yes. So I did use my tube.
Look at you.
So yeah, like with ProStride.
maybe your eye kit, like. He won't even look at an eye. He'll look at it and say, one of the other doctors needs to come and look at this.
You know, I have kind of delved off into orthopedic and performance land. And,
same thing with teeth. He'll be like, you should have somebody look at that.
Yeah, we need to get on that side of therapies, yeah.
He'll say, you should call somebody about that.
Yeah. I mean, let me send Dr. Zoe out. She's really good with teeth. She loves teeth.
No. What are the other ones?
So, yeah, like we talked about, we're going to do a whole episode on ProStride because that's how cool it is. But, yeah, ProStride.
Well, there's just a lot to talk about with ProStride,
Yeah.
and it deserves its own episode, or like
Right.
most of an entire episode, because there's just a lot to cover. But
Yeah.
ProStride, IRAP, and PRP together.
And then we're
Which is
now
wonderful.
sneaking a little alpha-2 macroglobulin in with there as well. But
So it's like really like,
yeah, we've kind of taken it to the next level, but we'll talk about that in that episode. One of the other things that we sometimes use is a product called Renovo in joints as well. Renovo is made from the placenta of mares. We use it a lot in tendon and ligament injuries.
Renovo is equine amniotic allograft.
Yep.
So that, yeah, exactly. And it's a liquid product that is kept in the freezer that we bring out with us on an appointment, and it's like in these little vials. We unfreeze it and we inject it. So we're not there. It's not like IRAP, PRP, or ProStride where we're actually harvesting your horse's own blood, spinning it down and injecting it right there at the appointment. Those are harvested from your horse and put back into your horse. Renovo is already a packaged product that's coming from a different horse, is amnion, like from a mare.
So it's part of the placenta when they fall out.
Correct. And it's basically just they're harvesting growth factors from the amnion.
It's purified growth factors from the amnion.
Yep.
And it actually has all these same growth factors that PRP has. Does actually have some IRAP protein in it as well. So there are times we'll reach for it, but those are very specific issues. Usually if I've got a collateral ligament tear, I'll look heavy at using then it's always the debate between ProStride or Renovo, and there's a lot of things that go into that decision.
Yeah.
Maybe
we can
we'll dive into that when we talk about ProStride. We'll dive into that a little bit.
Okay. Yeah, that's it.
The other thing we talk about that you brought up was stem cells. When do we put stem cells into a joint? One of the things I think is really important when we talk about stem cells in a joint is this needs to be what we call an autogenous graft. Those stem cells need to come from that horse. There are a few off-the-shelf stem cell products that you can order that are allergenic for tendon and ligament injuries. They work fantastic.
Do not put stem cells from another horse into your horse.
Correct.
Because Renovo is not stem cells. Renovo is not synonymous with stem cells.
No.
Renovo is acellular.
Yes, no cells in Renovo.
Right. Correct.
Stem cells obviously are cells.
Yeah.
And what we have seen, and I'll tell you, interesting enough.
You want a nice little joint flare.
Yeah, when I first started, stem cells were just becoming, like they were experimental. And then when I first started, they were becoming more and more mainstream, and we were using these allergenic grafts or stem cells from other horses into horse joints. And we later found that it's actually, a stem cell from another horse can actually cause it can actually create inflammation and create all these bad things that we don't want.
Well, that's what I was thinking. I was like a nice little joint flare because it's seen as a foreign substance.
Right.
The horse's body will see it as foreign,
flag
it, and say, "Whoa, what is all this stuff doing in here?"
And it's interesting to me because that doesn't happen. If I'm treating a tendon or a ligament, it doesn't happen. But for whatever reason, inside the joint's like, no, I don't like this. You're not supposed to be here.
Maybe because the joint is not really supposed to contain a whole lot of stuff anyways.
It should be pretty acellular.
Yeah, the joint, like the average cellular count of joint fluid should be quite low in a normal horse.
Less than 500 cells per mil.
Yeah, it should be pretty acellular, relatively speaking. And so maybe that's why the body is just kind of already on high alert. And
Makes sense.
Come in and
average dose is around 15 million cells.
Yeah, that's a little high.
So we went from should be less than 500, and we just put 15 million in there. And I can tell you these joints are not.
All the alarm bells are going off.
Yes. So any good the stem cell could do, it's doing way more bad. So, I think that's your biggest thing you got to remember on stem cells is you don't want. You have to use that horse's stem cells. Mm-hmm. Don't use another horse's stem cells. Tendon or ligament, you can use another horse's stem cells, and they do just fine.
Yeah.
Joint, no. So, all right, I think that's, kind of tie everything together. We're going to dive into ProStride in the next episode. But Biologics, great products, a lot of difference on the market. Our goal is going to be kind of go through some of these individually and select when we use what and where. The biggest thing we want to cover today is how they work and why they work. I use quite a bit of biologics in my practice now. I don't know how many you're using these days, but I've gotten where I'm using more and more of them.
Yeah,
And-
I would like to use more. I think maybe the downside, and hopefully in the next couple of years, it will become a little better. The more mainstream it becomes, I think the easier it will be to convince people that it's important. It's kind of like steroids have been the gold
Around for
standard
30
for so
years.
long. People just kind of expect it versus when you anytime you bring a new product out, people are always a little like, I don't know, especially when it's more expensive because biologics are more expensive because you've got all the kits and you've got all the machinery
process,
and it's not just a little vial of steroid you pull out and shake it up, draw it up, inject it in. Logistically speaking, the vials of steroids super easy, whereas all the biologics are a little bit there's a lot more involved in it.
There's a lot of upfront costs in
I would
starting
love
to
to
do these.
use more biologics, but the cost associated with them is more expensive, and then convincing people to use a new product is a little bit trying to explain to them.
And one of the things that we really didn't touch on much that we need to talk about is, one of the great times to start looking into using a biologic is horses that are insulin resistant or even cushingoid. Because
Horses where it's kind of dangerous to
Right.
use a steroid putting steroids into their body could potentially send them into a laminitic episode. Would definitely benefit from, say if you have a chunky little quarter horse that you need its hocks injected because you're getting ready to go to the show soon, is already a little bit insulin resistant.
Yep.
You don't want to, if you can avoid putting extra steroids into that horse's body,
Absolutely.
you better reach for the
Well,
biologic first.
And one of the things that has really changed the use of these biologics is a friend of mine, Vern Dryden, big shout out to him. He developed a test called the Wellness Ready insulin test. This is a stall side test. We can pull blood on your horse 15
This
minutes
is not a
later.
sponsored ad.
It's not. I get no sponsor from this, but I'm just thankful.
None
Vern-
of this is sponsored,
Yeah,
by the
Vern
way.
worked with me in
None of these
podiatry.
products we
Yeah.
talk about, we do not get kickbacks from.
No, he worked with me in podiatry.
At least I don't.
No, I don't either. But it was one of those things.
Are
we
you getting
saw
money that I'm not getting?
So many horses that had issues because they got injected with steroids that were insulin resistant, and we didn't know they were.
Yeah.
And so having this test where in 15 minutes I know if your horse is insulin resistant, I go in there and this insulin's off the charts. One, we're having to talk about that, but then two, I'm like, hey, we're going to a biologic
Yeah.
because
so
we're not
here's-
going to fix one thing and cause another. Because even if you save the synovium and you save the world, you cause laminitis, and now there's a whole nother issue.
Yeah, so he's basically talking about, we come out to do a performance evaluation on your horse because you think your horse is a little off, not performing at its best. Do all the flexions. We say, hey, we think your horse needs his ox injected. And we're like, but he's a little on the chunky side. We're going to pull some blood just to measure the insulin because it looks like he could be insulin resistant.
Yep.
Insulin turns out to be off the charts. We're not going to put a steroid into
No,
that horse.
you
That's the
don't want us to
last
put a
thing
steroid
we're
in that
not
joint.
putting a steroid into your horse's hocks. We're going to reach for a biologic because you ain't going to the show if your horse is foundering.
No. So, all right. Well, that kind of ends our time. So we had a great talk. we kind of laid out the basics of regenerative medicine. We got an episode coming. We're going to take a deep dive into ProStride. So we're going to be talking a little bit more about this. We're going to talk about what it does, how it works, kind of another overview of how all these biologics are integrated as well. So, Dr. Zoe, thanks for being here today.
Thank you.
Thank y'all for tuning in, and we'll see y'all next time.